Welcome to Strategic Thinkers. In this new episode, we're going to have the great honor of having Dr. Angela Wong, who is a dear friend, but more importantly, is a leader in her fields, and he has worked and act very strategically throughout her career. So thank you, Angela, for being here. Do you want to give us a little bit of your background?
Thank you for inviting me. So, as mentioned, I'm a doctor and I trained and qualified at University College London, following which I did a series of training jobs to my current specialty, which is gastroenterology, and this was undertaken within many of the hospitals within London, UCL, Royal Free, and the St Bartholomew's hospitals within North East London. I then did a period of research in Cambridge, following which I became a consultant within Barts Health, which is my current job. I've currently got a portfolio career, so as well as being a clinician, I'm a group clinical director at Barts Health, which is the largest acute trust in the country, as well as the chief medical officer for the North East London Cancer Alliance, which spans the 7 hospitals within North East London, as well as primary care and population.
This is fantastic, and is your career spans many different type of jobs, from the very scientific deep end to leading. Today we're going to talk about your role in leadership, and what the audience is interested in this type of podcast is really to see the different thought processes that you put in place to take great strategic decisions. And the great thing with you is that we're going to do it in a domain that where profit is not the outcome that is sought after. Of course, you need to do it within the budget, but you're looking to, save people and make life better for millions of people that have, unfortunately, some disease or illness. Now, in terms of the topic of today, what kind of challenge do you want to share where you apply strategic thinking throughout your career?
I wanted to describe a project which is now live and open for the Early Diagnostic Centre that I bid and created a case for alongside others in North East London, which importantly increased capacity significantly for diagnostic tests. And the reason this is important is that we now have a 1 in 2 lifetime risk of cancer, and we want to improve cancer outcomes. And in order to improve cancer outcomes, over 95% of patients who are referred in on an urgent suspected cancer pathway, if not higher, will have to have diagnostic tests. And so there was a very important need to increase that diagnostic capacity.
Do you want to take us through what was your vision when you and your team, they thought about doing this bid for this project? What was the vision? What was the ambition and the problem you wanted to solve? I mean, clearly you wanted to say, but there is many ways that you can save lives. So what was your vision at the time?
So I think firstly, we had an opportunity that allowed us to take forward the vision, which is actually to improve cancer outcomes and to increase the capacity for diagnostic tests. And one of the reasons that we were starting to see as more referrals were coming in was that we were having to put on additional lists that were high cost at the weekends and sometimes even into the evenings, which is obviously not good value within the NHS. So this was an opportunity, firstly, to take a data-driven approach, to see what that increase in demand was, to see the mismatch in our demand and our capacity, and to look at how we could create value by perhaps having one centre that would serve all 7 of the hospitals. I think there was a point in time where, each, for example, of our endoscopy units felt, we needed 2/3 of an additional endoscopy room. And so rather than adding on 6 endoscopy rooms, we were able to create 2 within one centre. So I think a data-driven approach, and I think one of the things that we did, in this, how do we improve outcomes, was we looked at the data for emergency presentation. And we know that if you present with cancer in the emergency department, 95% are going to be the most advanced stage 4, with poor outcomes. So by shifting to increase that capacity and to have patients come through what we call the elective route, a GP referring in, that was really important. But when we looked at the breakdown of the specialties, we had to prioritise. So we knew that lung cancer was one of the highest, but we were already involved in a programme that was looking at a lung health check, which in fact has become part of a lung cancer screening programme. And then when you looked beneath that, it was the sort of gastrointestinal cancers like colorectal cancers and liver cancer, which is increasing in incidence coming through. And so therefore, these were, if you like, the priority. So it was creating a prioritisation within the cancers because we couldn't do everything in one go.
And did you set yourself some ambitious target when you were doing this? Were you thinking with some sort of measure of success? Was it number of patients cured? Maybe savings? What you and your team had in mind as to, let's say, I don't know how many years ago you had this, but in X number of years, success will mean?
Yeah, I mean, we really had to put these key performance indicators in, and that included working out, how many tests would we do within the capacity. Really important for me in, another ambition, which was to remove unwarranted variation in access, is to have a 7-day service and long days. Which would make us more efficient and provide more choice for patients so that they could attend and not turn up, which is another inefficiency. So we looked at how much was being spent in doing these expensive additional lists at the weekend, so where people were basically being paid overtime rates, and we worked out how much that would cost, and so we then put that into sort of a business as usual model with people working 9 to 8 to 8 within a week, rather than doing this as overtime as part of their job. And so the financial model was one, the increased capacity was the other, but it was also important that we actually looked at the additional cancers that are being diagnosed and how efficient we were.
So you really had a balanced set of KPIs, some that cover the patient, some that cover more the operations, so the efficiency, some that perhaps look more at the financials. That is a very, very business-minded approach. In strategy. We call that a balanced scorecard. Like a mix of KPI that balance each other rather than just financial. And in terms of choosing, of course, you are in the non-for-profit world. And you have an ambition, but then how did you segment the market? How, you mentioned that you looked at the different categories of diseases, in particular the cancer, and then you went for lung. And where other analysis that you did, for example, in terms of population that you wanted to target? Could you take us through that thought process?
So we did do sort of population health analytics. Where are we seeing longer waiting times across, and there was variation within our region. So that was an important in terms of, if we develop this capacity that's on one site, how do we ensure equitable access for all? So I think it really is that data-driven approach and seeing where we had variation and seeing where, there's a good case for change to change that.
Great. And now the next question is more about how do you, although again you are in a constrained world, how do you differentiate yourself from the other offering? And how it's terrible to use the word win in healthcare, but how, surely when you designed this project and the strategy behind it, you were thinking about, well, how can I differentiate my offering from the others? That could be also non-existent offering, but also you're competing in a global world where people are mobile and they can move from one area to another. So what was your, the decision you took, and what was the thought process behind it?
Well, I think it was having that clear vision and case for change. And I think, bringing all the stakeholders on board. And I think one of the things that we did fairly early on is I created a patient group of patients who had diagnostics. And again, so it was a co-development of the project, and therefore, if you like, going around. And so one of the things we had to do is actually go around to oversight groups in the community. We had to go and visit all the different hospitals, really to get bringing everybody on board to what was actually a very different model. And when we succeeded in the bid, it really was where you've got the money, you're describing a diagnostic facility that will serve primary care as well as a broad group of hospitals, but you're docked onto, from a governance perspective, one hospital, and how do you oversee the governance of that? So I think that was, we established working groups. So we would have a finance working group, an estates working group, a clinical pathways working group, the patient group, and also and that allowed, and if you like, and then we moved into an implementation phase, which was working through the detail of the governance as to how could people access it, and we had a digital group as well. So how, if you're from a different hospital, can you actually refer in digitally when that infrastructure doesn't exist?
This was a very collaborative exercise, or co-creation. We call it. We call it in strategy exercise. But going more into the service offering, how did you decide? Where did you want it to win? Was it the most efficient? Was it the most technologically advanced? Was it the most effective? And what were the attributes? Having spoken to so many different stakeholders, probably all with conflicting interests, because patient group, they want the best treatment. But then if you're looking at the payer, it wants something that it balances value for money. So what? And later we will discuss about your success. But this has been successful. And how did you win? So what were the attributes, if you want? That through all those discussions, you say, in order to win and not only getting the money, but then succeeding in implementing it, what were the 3, 4, 5 things that you really wanted to be better than others? And others that you said, I just need to be at par?
So I think one of the biggest things was the compelling case for change in terms of value. Okay. And it was different in terms of, it was really patient-centered. The offering of long days, 7 days a week, taking away the concept of a weekend in terms of diagnostic tests, it was different. And I think that
both for the probably for the physician, for the payer, and for the patient, because also for the patient the weekend is not convenient. For the physician, the weekend is also not convenient. And if you do use physician in the weekend, you have to pay more. That's
so that was what we didn't do. We paid the same rate. It's a 7, but then you may get a day off in the week, and because you do long days, maybe you're getting 2 days off or more in the week. So I think it was listening to the stakeholders, but and I think I would say the data-driven approach. This is why we need to do this. This is the vision, linking it to the vision and linking it to value.
This is amazing. Now, you already spoke a little bit about the implementation, but let's fast forward. So you won the bid, you got the project. So how did you sequence, and what were your activities in order to create the team, to maybe purchase and or refurbish the technology, organize the processes? Did you have a blank piece of paper, or you had something already? I mean, you had definitely your experience. But how did you go about it? So now you got the project, somebody bought your vision, you got the funding. So what did you do, and how, what were the phases, and where you are at the moment?
So once we got the funding and it was secured, and I think that it was a huge collaborative effort, because in order, one of the things I haven't described is in order to get it signed off, it had to be agreed by all the hospitals in North Central and North East London, because this was money available for all, and to say, well, actually it needs to be here for these reasons. And once we had secured the funding, and again within that there are challenges, because the sort of NHS England rules and Department of Health rules is that it has to be spent in the financial year. How do you build it in the year? So the first focus was actually on the estates infrastructure. How do we get that team together to take this on as a project and to work with them together? They're actually part of the team to actually get the build, and obviously you have to have the surveys, you do the you start, and then you have to have a procurement process, it's standard, and so and once the build was underway, and we then started to focus on the clinical pathways and the equipment that would go in. So I think that's why we had to form a governance framework, so a steering group where we would oversee the programs that would lead on the clinical pathways, the digital aspect, the estates aspect, the finance aspect, and our patient group aspect. So I think forming these groups, and then once we hit a point where we knew we were coming towards the completion of the build, we then had to go into operational readiness phase, which brought in more of the operational colleagues.
And how did you convince all the, this seems a very complex,
it was.
And I guess, how did you communicate the vision? How did you get those teams to be on board? And, because it's very easy with such a variety of teams that everybody goes right, left and center. How did you steer that?
So I think probably a big part of it was the stakeholder engagement. I had to go to the various hospitals, I went to the various boards. You know, you have to follow a governance framework for getting it commissioned. So I had to go to what was called the SDP, it's now the ICB. That's the body that, if you like, has the financial oversight of the region that you're working for, to actually get the additional capacity agreed. So they would agree to, if you like, although we had the capital, they had to agree the revenue to pay for all the additional workforce and understand that this was a value proposition. So that was one aspect of actually getting it commissioned. The second was actually getting the clinicians, the operational staff from each of the hospitals, as well as primary care, aware of what's going on. So if you like, there was a bit of a roadshow to get that, to get the, you know, you have the early and the later doctors on board, etc. You know, there was a change management process, definitely.
How long did it last, this process, to day one of the launch?
Probably longer than one would have liked, so over 2 years.
Yeah.
And what actually happened was that we had an ultrasound part of it as well, and then an MRI model that came on later. But when COVID happened, you know, suddenly this concept of having a diagnostic centre that was away from the emergency department became a COVID minimal site. And so actually a green site. So patients who wouldn't want to go into their hospital to have their cancer diagnostic test would go to the early diagnostic centre. And I'm pleased to say that following on from this, there was a review by Professor Sir Mike Richards, who we had presented this model to, and then, you know, the government actually invested sort of 2.3 billion in this model. So there's now community diagnostic centres.
So you had many more side effects because, of course, through COVID, you know, going to hospital would have been a death sentence in many respects. Now, let's talk a little bit more deeper on those 2 years. So you clearly have done a lot of work on communication and engaging the people, sharing the vision. But of course, I guess that there were some hurdles or some barriers. How did you overcome those? I mean, there's no need of a specific. It's just as a leader, you know, you always have to go against inertia. And people have done things in a certain way. You're coming in with a completely new model, you know, doing a large investment. So there is a lot of money at stake. There is a lot of people at stake. So what kind of, you know, barriers did you face aside of the communication part? And how did you, you know, overcome them as a leader?
Yeah, I mean, first of all, not to take it personally, because there were a lot of challenges. So once, if you like, we got the money, there was a bit of, and when I say we got the money in North East London, having got the agreement of all the hospitals also in North Central London. You know, there was a bit of potential other colleagues saying, well, actually, we need this diagnostic equipment. You know, could we just take off 1 million and, you know, you have 4 million? And I said, well, you know, you can't build, you know, 80% of an early diagnostic centre. We actually need, that money. So again, it was going through the round of convincing, not taking this personally, not getting upset, but just reiterating through the data-driven approach, the compelling case for change, and the ambition. Okay, so I think that it wasn't just we want additional capacity. We wanted to innovate within that. We wanted to increase research within it by cohorting some of our patient groups, for example, or the opportunity for research. And I think, you know, from a sort of we are not necessarily business orientated, you know, but we do look at value within the NHS. You know, I think I remember there was a time where I wondered, you know, who needs to make this decision? And I did follow I can't remember the acronym of it, but it's somebody JAGO, where about a decision-making trees. Did I need to get all the stakeholders to agree, or could I make that decision? And I found that really helpful, because when I did the marble run on that, it's like, actually, no, you can make this decision. Are you
referring to RACI or responsible, accountable? It doesn't matter. There is a lot of acronym on this.
That's right, so a decision-making tool, basically.
Absolutely.
So
and when you're talking about decision-making, it's always very, you know, there is a framework I use a lot, which is when you're talking about strategy, there are certain things that are non-negotiable. So clearly, on certain things, you were very sturdy and strong. Then there are things that are adoptable and adaptable, so that you may want to adapt it, or adopt it and adapt. And then there is what I call freedom to act. You know, things that you will lead the different teams, a lot
Yeah.
of freedom of design authority
Yeah.
on how to design. So in such context, now, what were the outcomes? So now we are day one,
Yeah.
we are probably many
Yeah.
days after. So
Yeah.
how has this project unfolded over time?
So we opened asynchronously. So in the beginning, we wanted to open the endoscopy and the ultrasound part together, but actually we opened the ultrasound because the COVID happened and we actually needed the capacity. And so we opened phase one, which was the ultrasound. Then we opened the endoscopy unit, and I think we opened it in quite a good way in the sense that we opened it in a phased manner, not like 2 rooms full pelt 7 days a week. You know, it's like 1 room several days a week to 7 days a week, then you bring the second room online. And the reason for sort of staggering it as well is because the model that we had from a clinical point of view is we got clinicians to come in from the various centres, and I had a sort of secondary aim from that, because if clinicians come to work within the same diagnostic centre, then hopefully best practice can be across the piece as well.
So not only you have a more efficient place,
Yeah.
but you also have a hub
Yeah.
where the
Yeah.
all the competencies that are spread across
Exactly.
the different hospitals.
Yeah.
I see. And do the patient have to travel to
So patients have to travel, and again, one of the important KPIs that we monitor is the patient experience, and it's really high. I mean, you can Google it on top of what we do, from patients visiting. You know, the friends and family test, and the feedback we get is excellent. People often think it looks like a private hospital, which again, very deliberate with the choice of the sort of furnishings and the flooring, the doors, which I know this might sound funny. The brief I gave was, let's make it not look too NHS-y, right? Mm-hmm. So actually it does look like a private centre. And I've been fortunate to go to Virginia Mason, and I looked at the sort of efficiency of the flow of how people come into an endoscopy unit or come into wards. And what previously happened is people might come into sort of an open ward or one room, go and have their endoscopy, and then go back to a different room or a different ward. What we had was, this is your admission room. So it felt like it is a private room, and this is the room you come back to after your endoscopy. So again, just another
really
example
thinking like a customer journey. I mean,
yes,
a patient
exactly.
journey in this case,
Yeah.
that from the beginning to the end. So, what would you say are the outcomes? I mean, clearly it has been extremely successful, but what would you say you and your team are very proud of, and what are the benefits for the different stakeholders? Because you had to pitch the benefit to get the funding. Now, years later, the center is up and running and very successful. What would you say are the greatest achievements that have been achieved so far?
So we have additional capacity that is not fallow, right? I think that demand capacity modelling was really important, and not to do it to say, well, we're going to have an extra 5% headroom. There's no point in doing that, because we need to become more efficient, and we actually need to understand that technology might reduce the number of tests or some of biomarkers may actually reduce the number of tests rather than forever needing more. And then, so we've done more diagnostic tests, but that also means that patients have been waiting less to get their diagnosis, which I think is really important. I think it has created jobs, and it's become, and it is financially cheaper than having an overtime model.
And of course, if we look at the healthcare models, the diagnosis and early diagnosis, it's whenever something becomes chronic, the costs are going out of control. But not only the cost for the payer system, but the cost for the patient, because that he might not be able to work or not work as much, and so forth. So now, to conclude this beautiful talk. Think of someone that is in your position, that is going to step into a project of this magnitude. What would you say are the 3 lessons learned that you would like to share with our audience, so that they could, 3 or 5 or 1, what are the lessons learned that you would recommend people to take in consideration when they get into a project of this magnitude?
I think tenacity. You've got a vision, follow it, but bring as many stakeholders as you need to do that. Have a data-driven approach, and think about value.
That's fantastic. So thank you very much, Angela. This was a fantastic talk. As you know, we will have also a written small article or case study which you will look at. But thank you.
Thank you very much for inviting me.